Chromoendoscopy with targeted biopsy to detect nonpolypoid colorectal neoplasms in inflammatory bowel disease. The authors wish to thank the generous, unrestricted educational gift from the Jack and Maxine Zarrow Family Foundation. In conjunction with this program, we encourage viewers to read the referenced article on the detection of nonpolypoid colorectal neoplasms in patients with IBD to optimize learning. IBD patients have an increased risk of colorectal cancer. The major risk factors for the development of colorectal cancer are the disease extent and duration, the activity and severity of inflammation, post-inflammatory pseudopolyps and strictures, which make surveillance difficult, primary sclerosing cholangitis, family history of colorectal cancer, and, most importantly, the presence of dysplasia. In patients with IBD, endoscopists commonly perform random 4-quadrant biopsies every 10 centimeters in the colon for surveillance of dysplasia. However, chromoendoscopy with targeted biopsy of abnormal mucosa is recommended by the British Society of Gastroenterology, the Australian Cancer Council, and the American Gastroenterological Association. The AGA in particular recommends chromoendoscopy to be used if endoscopists have expertise in the method. However, learning the method can be challenging as video descriptions are rare. Here, we will describe the technique and several illustrative examples. Studies suggest that the current standard of random biopsies to detect dysplasia in IBD patients is inadequate. In this study of 55,000 Medicare patients diagnosed with colorectal cancer, cancer patients with IBD were 3 times more likely to have had a recent colonoscopy than other cancer patients. In 15% of the IBD colon cancer patients, the cancer was a missed lesion, and the patient had undergone surveillance colonoscopy in the prior 3 years. In patients with IBD, random colon biopsy is the standard practice to detect and diagnose dysplasia. Here, we outline the random biopsies taken of this area, as seen by the blood, that unfortunately miss this unrecognized depressed lesion. At routine surveillance 1 year later, a large, depressed mass was identified at the same location. After biopsy and EUS staging, a T2 into poorly differentiated cancer was confirmed. Clearly, random biopsies have their limitations. Data now supports the use of chromoendoscopy with targeted biopsy. A systematic review and meta-analysis through January 2013 identified 6 articles that provided data on the association of chromoendoscopy with targeted biopsy and dysplasia detection in inflammatory bowel disease patients. In the meta-analysis of 6 clinical trials comparing chromoendoscopy to white light endoscopy, chromoendoscopy detected additional dysplasia in 7% of patients compared to white light endoscopy. The number needed to treat to find another patient with at least 1 dysplasia was 14. Chromoendoscopy with targeted biopsy increased the likelihood of detecting any dysplasia by 9 times compared to white light, and the likelihood of detecting nonpolypoid dysplasia was 5 times higher. The potential of enhanced mucosal visualization in colitic patients is demonstrated in this case of a missed flat lesion during surveillance colonoscopy using white light and random biopsy alone. When dilute indigo carmine was sprayed throughout the colon at next surveillance, this subtle lesion became visible. The value of chromoendoscopy is evident here. On the left, the lesion is difficult to appreciate with white light endoscopy, but after application of dilute indigo carmine, the lesion and its borders are seen. It is important to understand the technology of standard and high definition in the context of lesion detection. High definition increases the resolution of the image. For example, high definition captures at least 720 pixels from top to bottom, whereas standard definition captures 480 pixels. This is demonstrated here on the right of the screen. In high definition, the line is solid, and in standard definition, it is dashed. Here, in standard definition, the image of this polyp lacks detail. High definition shows the same polyp, now with more detail. However, the greater detail does not particularly highlight the contrast between the normal and abnormal mucosa. By contrast, chromoendoscopy with indigo carmine provides the necessary contrast to detect and diagnose dysplasia in the colon of patients with IBD. As shown here, the dye contrast is particularly helpful as it pulls into the mucosal crevices and delineates the lesion topography and surface pattern. Whereas high definition is about increasing image resolution, chromoendoscopy is about increasing image contrast. This distinction is important in detection of lesions and their borders, particularly non-polypoid ones. Data is not available to date to show that high-definition colonoscopy alone is sufficient to detect flat dysplasia in IBD. This case further exemplifies the difficulty in identifying the borders of a lesion using high definition alone. Using white light high-definition colonoscopy, the polypoid portion of the lesion can be seen. Upon application of indigo carmine, the flat portion of the lesion and its borders are now delineated. There are many image-enhanced endoscopy techniques in the colon and rectum, including dye-based and equipment-based techniques. For a comprehensive review, we refer you to our educational video on image-enhanced endoscopy, available through the ASGE Learning Library. In this video, we will focus on the application of image-enhanced endoscopy techniques in patients with inflammatory bowel disease. Evidence to date shows safety and efficacy of the use of the dyes indigo carmine and methylene blue for colorectal cancer surveillance in IBD patients. Equipment-based image-enhanced endoscopy techniques, such as narrowband imaging, have not shown efficacy in this patient population. We recommend the use of indigo carmine as the safety of the endoscopic use of methylene blue is unclear, with studies suggesting potential carcinogenesis. Experimental studies have shown that methylene blue can bind to and intercalate with nuclear DNA. In vivo studies of colonic and Barrett's esophageal mucosa have demonstrated increased risk of DNA damage and further carcinogenesis in rat stomach models. Furthermore, because methylene blue is a vital dye, the cells take up the dye, making it technically more difficult to use. The mucosa remains stained, making the field darker and more difficult to visualize. The current nomenclature for IBD-related dysplasia is confusing. Adenomas occurring outside an area of disease involvement are presumed to be typical sporadic adenomas. However, dysplastic lesions or masses, referred to as DOMs, that occur within a diseased area are classified as adenoma-like or non-adenoma-like, according to whether their endoscopic appearance resembles a sporadic, endoscopically resectable adenoma or not. So-called flat dysplasia may be truly invisible, in which case it is only detected on random, non-targeted biopsies, or visible, in which case some people may refer to it as a DOM, especially if it is slightly elevated. It is currently believed that almost all dysplasia is visible with routine or enhanced endoscopy. We prefer the same classification system for IBD-related dysplasia as for non-IBD neoplasia. That is, dysplastic lesions are classified as polypoid or non-polypoid. Polypoid neoplasms may be further subclassified as sessile, Paris classification 1S, or pedunculated, 1P, and non-polypoid lesions as slightly elevated, tabletop, Paris classification 2A, depressed, Paris classification 2C, completely flat, Paris classification 2B, or perhaps invisible, being an unrecognized non-polypoid lesion. Rather than using the terms adenoma-like or non-adenoma-like, we think it is clearer to describe lesions as endoscopically resectable or unresectable. This patient was undergoing routine surveillance for chronic ulcerative colitis, which had been in remission. After spraying with dilute indigo carmine, a thickened fold with ulceration is noted. The surrounding mucosa appears relatively normal. Upon hand spraying with concentrated indigo carmine, a 3 cm flat neoplasm is well seen with a homogeneous adenoma pattern. This was a superficial elevated, tabletop flat, Paris classification type 2A neoplasm. During surveillance colonoscopy in a long-standing ulcerative colitis patient, attention is drawn to discoloration of the erythematous mucosa. Upon further inspection with white light, it is a slightly raised lesion. Upon selective indigo carmine spray onto the lesion, the depressed center can then be appreciated. Depressed morphology is most concerning to harbor advanced histology. Using older generation colonoscope models, we could imagine that a subtle lesion such as this could have been deemed invisible and missed. Using new models with high definition and improved technologies, the slight erythema and mucosal deformity could be seen. Further detailed inspection using indigo carmine chromoendoscopy delineates the borders of the flat lesion, revealing it to be much larger than appreciated with white light. Indeed, upon further inspection of the neighboring mucosa, a synchronous flat dysplastic lesion is seen. A small, completely flat Paris 2B dysplastic lesion, as shown in this case, would be quite a challenge to recognize without chromoendoscopy. Using high-definition instruments, we perform image-enhanced endoscopy with indigo carmine using 3 different concentrations. Varying the concentration is important depending on the indication. For example, if the solution is too concentrated when spraying the entire colon, then it can make the colon dark and impair inspection. The corollary is when selectively spraying indigo carmine on a lesion for detailed inspection. If the solution is too weak, then it does not enhance visualization or contrast. For screening of dysplasia in IBD, we spray dilute indigo carmine through the forward wash jet, targeting all suspected mucosal irregularities. The forward wash jet solution is made by combining 2 ampules of 5 cc's of 0.8% indigo carmine with 250 cc's of water. When lesions are identified, more concentrated indigo carmine, 0.8%, 5 cc ampule of indigo carmine mixed with 25 cc's of water is applied with a syringe via the biopsy channel to better delineate the lesion extent and the mucosal detail. The technique of chromoendoscopy is shown here. Using high-definition instruments, dilute indigo carmine is applied using the forward wash jet. When lesions are identified, more concentrated indigo carmine is applied via the biopsy channel to better delineate the lesion extent and the mucosal detail. Targeted biopsies are then taken of the lesion. Biopsies are also taken around the lesion to exclude flat, invisible dysplasia, which would render it endoscopically unresectable. Red flags for flat dysplasia in IBD include slight elevation, focal friability, obscure vascular pattern, discoloration with uneven erythema, villous appearing mucosa, or irregular or nodular surface pattern. Appreciation of the appearance of advanced cancer and its distinctness from early cancer is a prerequisite for IBD surveillance colonoscopy. The advanced colitic cancer shown here in a patient with long-standing ulcerative colitis is not appropriate for chromoendoscopy or endoscopic resection. We will now describe how to perform quality chromoendoscopy with targeted biopsies. First, whenever possible, the disease should be in remission before surveillance is undertaken. Active colitis causes changes in mucosal color, texture, and vascularity that can be extremely difficult to distinguish from nonpolypoid neoplasia. Furthermore, mucosal inflammation and regeneration can cause cytological changes that can mimic dysplasia. Patients should prepare for colonoscopy using the split-dose bowel preparation. Excellent bowel preparation quality is imperative for optimal screening. Focus on the importance of bowel preparation quality cannot be overemphasized. Irrigate the colon during intubation. Any remaining residue should be meticulously washed and suctioned prior to the application of chromoendoscopy. When the blue dye mixes with the bilious stool, it turns green. After complete insertion of the colonoscope, examination with the chromoendoscopy begins in the cecum and proceeds methodically. During withdrawal, each segment is sprayed and carefully inspected. For optimal application and efficiency, use the foot wash pump for spraying and target the spray to the anti-gravity wall of the colon. Suction any excess dye that pools so that a thin layer remains and the mucosa is not obscured by blue pools. Expand and collapse the lumen with air insufflation and suctioning during chromoendoscopy examination. We will now demonstrate the proper technique.
So we're going to now change to indigo carmine diluted through the foot pedal. We use 2 ampules of indigo carmine and 250 cc's of water. With the indigo carmine spray, this area is a little better defined. And now we're going to do targeted spray. This is more concentrated, 1 ampule, 5 cc's in 20 cc's of water. You can see the borders of this area now.
A flat lesion overlying a fold, such as shown here, can be mistaken for a fold. It is thus important to evaluate the surface pattern and compare and contrast it to the neighboring mucosa. Lesions seen on chromoendoscopy are examined closely to determine their border and endoscopic resectability. This is a patient with quiescent ulcerative colitis undergoing routine surveillance. A slightly elevated lesion is poorly visualized with high-definition imaging in a region involved with colitis. Upon application of dilute indigo carmine, a large, flat neoplasm is well seen, which has discrete margins, and it appears to be much larger than initially predicted by white light imaging. The lesion was felt to be endoscopically resectable and was removed with ESD. In this patient with ulcerative colitis, an irregular lesion is readily seen with high-definition imaging in an area of chronic colitis. Nonetheless, with application of indigo carmine, the lesion is better delineated. In contrast to the prior case, this lesion has several features that indicate that it is not endoscopically resectable. It is poorly circumscribed, has an indistinct border, and has an irregular, plaque-like surface with a depressed center. Biopsies confirmed high-grade dysplasia. Surgery is the best treatment. In addition to enhancing the border, chromoendoscopy makes it easier to examine the mucosal surface of lesions. Using high-definition imaging, endoscopists can discriminate between inflammatory polyps, serrated lesions, and lesions with low-grade dysplasia, high-grade dysplasia, or invasive cancer. It is unnecessary to biopsy or remove obvious inflammatory polyps or lesions, such as seen here. However, when in doubt, biopsies are recommended of all suspicious lesions to exclude dysplasia. This 35-year-old male with an indeterminate colitis had a 1 centimeter polypoid lesion within a colitic area. Biopsies excluded dysplasia and confirmed chronic inflammation. In this patient with long-standing chronic UC, dilute indigo carmine demonstrates a large, well-defined nonpolypoid lesion. The surface shows familiar features that resemble an adenoma and typically contain low-grade dysplasia. The surface of neoplastic colorectal lesions in IBD is atypical, often with irregular shapes and patterns. Lesions that exhibit such features often harbor high-grade dysplasia, as shown in this case. Again, with the use of chromoendoscopy, biopsies can be targeted to visibly abnormal areas rather than randomly applied. We emphasize the importance to biopsy the abnormal area that appears distinct from surrounding mucosa. Nonpolypoid lesions occurring within colitic areas may be removed endoscopically, provided they are well circumscribed and do not have features suggesting obvious cancer with local invasion. Whenever possible, nonpolypoid lesions less than 2 centimeters in size should be resected in one piece, i.e. en bloc, using EMR. Following resection, the mucosa around the site should be biopsied to exclude the presence of unrecognized flat dysplasia, which would usually require a subsequent definitive surgical resection. By contrast, when the endoscopist feels a lesion is unresectable or is uncertain whether the lesion is malignant, biopsies should be obtained from the lesion. In addition, biopsies should be obtained from the adjacent mucosa to exclude unrecognized dysplasia. In this patient with chronic colitis, a sessile lesion was identified with chromoendoscopy at 6 o'clock. Upon closer inspection, the sessile lesion was felt to have features suspicious for invasive malignancy. That is, the center of the lesion is depressed and the surface is amorphous with loss of mucosal detail. Hence, decisions pertaining to endoscopic versus surgical resection were deferred pending biopsy results. Biopsies should be targeted to the most concerning area of the lesion, as shown here, which confirmed invasive cancer. Surgical resection demonstrated a T1 N0 lesion. There are important limitations to chromoendoscopy with targeted biopsy. Specifically, the presence of mucosal inflammation or multiple pseudopolyps may affect the interpretation of chromoendoscopy, and in these circumstances, the need for random biopsy is still justified. In this patient, large pseudopolyps were identified obscuring the lumen. Random biopsies were obtained from these lesions and the surrounding mucosa. High-grade dysplasia was identified and colectomy was performed. Examination of strictures can be difficult as the luminal narrowing can restrict tip deflection, illumination, en-face assessment of mucosal detail, and targeted biopsies. In this video, we do not thoroughly discuss the examination of strictures. Nonetheless, the principles of detailed imaging is again shown in this case. Repeated attempts at biopsies of the stricture on prior colonoscopies did not yield dysplasia. On this examination, continuous water infusion helped to distend the stricture, allowing better visualization of an ulcer and targeted biopsies of the abnormal dysplastic appearing area. Biopsies confirmed carcinoma. Similarly, we will not provide a comprehensive review on the endoscopic resection of IBD nonpolypoid colorectal neoplasm. It is, however, important to understand that endoscopic resection in Crohn's or ulcerative colitis patients can be very difficult. Multiple biopsies for removal of such lesions must be avoided. Endoscopic mucosal resection is usually the most appropriate endoscopic therapy, noting still the high level of difficulty and risk of endoscopic resection for IBD lesions. During chromoendoscopy inspection, we identify a lesion that appears amenable to endoscopic resection. We proceed with endoscopic mucosal resection, first attempting to inject a mixture of diluted indigo carmine and saline into the submucosa to lift the lesion. Using the dynamic injection technique, we direct the injection into the lumen in order to mold the fluid bleb formation. We use slight upward tip deflection, suction the lumen, and nominally pull the needle catheter back, all while directing the injection into the lumen. In this case, the lesion lifted nicely to form a large bleb. We perform EMR, placing a snare at the normal surrounding edges for en bloc resection. In non-lifting cases due to underlying fibrosis, endoscopic submucosal dissection may be necessary for complete resection. This lesion was referred following repeated attempts at multiple biopsy removal. Recurrence is obvious, emphasizing the importance of proper and complete resection technique. Again, the practice of multiple biopsies with or without argon plasma coagulation is an inappropriate, ineffective treatment strategy and is strongly discouraged. Endoscopic resection in the setting of chronic inflammation can be difficult. The non-lifting properties of the nonpolypoid adenomatous lesion shown here in this patient with a history of more than 30 years of Crohn's colitis is a reflection of the difficulty encountered in the endoscopic removal of such lesions. Despite using a stiff snare, the lesion could not be captured for resection. Endoscopic submucosal dissection may be necessary for complete resection. Here is a nonpolypoid neoplasm in the rectum of a patient with long-standing ulcerative colitis. Significant fibrosis is present at the lesion. Endoscopic submucosal dissection is necessary in such cases to complete resection. Here is the summary of the technique. Starting at the cecum, spray dilute indigo carmine through the water jet during withdrawal. Dilute indigo carmine is made by mixing 2 vials of indigo carmine with 250 cc's of water. To view in detail a suspect area, spray through the accessory channel a mixture of 1 vial of indigo carmine with 25 cc's of water. Lastly, biopsy suspected areas or resect appropriate lesions using endoscopic resection. In conclusion, random biopsy to detect dysplasia and inflammatory bowel disease is inadequate. The use of indigo carmine with targeted biopsies of suspected neoplasms increases the efficacy of screening in IBD. This technique cannot be replaced with high-definition or equipment-based image-enhanced endoscopy. Thank you.